Okay, go ahead, Mohamed.
Okay, good evening, everyone. Welcome to FRCPCH platform. For those who don't know me, I'm Ahmed Shouk. I'm a consultant pediatrician. I worked in London in the UK, and I'm the president of the association. The British Sudanese Association of Pediatrics and Child Health, established first in 2003, and since then, the association has been working heavily with its members and trainees and other doctors in the UK, promoting training, providing many training activities, and supporting its member in the UK, both socially and providing some mentorship for their trainees. We also do a lot of activities with officials in Sudan to promote child health and support service delivery in Sudan, as well as training for the trainees who are working in child health. I'm just going to let you know, so I don't know if you can see this very well. This is the executive committee of the current committee that's serving for FRCPCH. That's me, that's Hani. Probably you can recognize some of the faces in here. Hani is the vice president. We have got Rihab Mahdi. She's the secretary. We have got Khalid and Arwa, who are working for the membership and treasury office. We've got Osama and Bahari for media and IT. We've got Dr. Mohamed Adam and Samah Bushra for the child health office. And we've got Nuha and Nadia for the academic office. So one of the missions that we are doing in this term, we are running a series of emergency pediatrics series, which is run by Osama. Thank you, Osama, for the great effort that you put it in this. And today you have your second series. The first one was, I think, general pediatrics emergencies. And the second one is today. And thanks for Professor Sarar, who joined us today. And he's a well-known in metabolic pediatrics, who's going to go through with you about emergencies in metabolic pediatrics. I'm going to introduce the team of the day, who's going to run the day with you. And I will start with Osama.
السلام عليكم ورحمة الله. أنا دكتور أسامة علي. دكتور أسامة علي, consultant pediatrician. How are you, and welcome all.
Okay, Rihab.
My name is Rihab Uthman, and I was one of the members of the previous steering committee. I am a specialty pediatrics, and I work in Northern Ireland. Specialty doctor, I mean.
Thanks, Rihab. Habab.
Good evening, everyone. My name is Habab Hassan. I'm a pediatric trainee, ST4, currently working in Oxford. Welcome all, and thank you for joining us this evening.
Thank you. Rihab. Manal.
Hello, good evening, everyone. My name is Manal Hamid. I'm ST8 pediatric trainee. I work at Chelsea and Westminster Hospital.
Thank you. And Buran.
Good afternoon, everyone. My name is Buran Khalifa. I'm a pediatric trainee at SO3 level, currently working in West Yorkshire in Leeds Hospital. Hope you a very fruitful evening. Thank you.
Thank you. Mohamed Usman.
Good evening, everyone. My name is Mohamed Uthman. I'm a pediatric specialty trainee, ST4 in Aberdeen.
Okay,
Welcome.
thank you for the team of the day. And a special thanks for them because they put really a good, big effort into this teaching activity to produce it the way that is going to go ahead with it. This is the program of the day. And is going to be through the Zoom. And I'm sure that most of you are much far better than me in using the Zoom. The first part of it is a lecture that's going to be delivered by Professor Sarar. And if you have any questions, then you can just put them in the chat box and will be answered at the end of the lectures. Following that, we have got like a screen break of 5 minutes, and then you will be directed into different workshops, and the team is going to divide you and you'll just find yourself into a break room. Following that, in the break room, so you will discuss a case per each group, and it's really important to assign one of you to come and present the case after the end of the workshops in the main room to the rest of the attendees. I just want to say that so the meeting is going to be recorded. If you have any problems with that, please let us know. It is really important after the meeting to complete the feedback form. It will be sent to you. And depending, for those who will complete the feedback form, we will send them the certificates of attendance in their email. And just important to say that so there is a CBD points can be claimed from the Royal College of Pediatrics and Child Health for attending this meeting. If you want to contact us for anything, this is the email, or you can just go into the chat and send a private message to FRCPCH and it will be answered promptly. Enjoy your evening and have fun. And please keep an eye on for the next series or the next activity of this pediatric emergency series. So I will leave you now with Osama, is going to go through the details of the day. And I wish you a successful evening. Thank you. Osama.
Okay. طيب السلام عليكم ورحمة الله. Dear all, we are very happy today to welcome you to the second series of the pediatric emergency medicine sessions. So today's session is going to be presented by Professor Sarar. I would like to thank him very much. Professor Sarar is a renowned professor in the field of pediatric metabolic medicine and newborn screening. So we are delighted to host him today, and we would like to thank Professor Sarar for his enthusiasm and willingness to participate and to contribute to our teaching activity. As well, I'm very happy and pleased to announce that this meeting is approved for CBT by the Royal College of Pediatrics and Child Health in the UK as per their current guidelines. So the meeting is planned to run for around 2 hours. We'll have a lecture at the start, as mentioned, that's going to be presented by Professor Sarar. Then we'll take some questions. We'll take around, the lecture is going to be around 45 minutes, and then take some questions for around 10 minutes. Everyone is going to be muted during the lecture. So if you have any questions, please write them in the chat box for those who are in the Zoom. For those who are on Facebook, please post your questions on the video chat area, and one of us is going to check the Facebook questions as well. Then we'll present this question to Professor Sarar at the end of the lecture, and we'll have a slot time for around 10 minutes for answers. So please feel free to ask, and we'll try to address all the questions. In case we run out of time, we'll email Professor Sarar so he can answer and try to get back to you via emails to address your questions. So then after that, it's going to be followed by a 5 minutes break at the end of the, and then start the second part of the meeting, which is going to be the workshop. The workshop will run for around 10 minutes. We'll have all the audience that are going to be divided into 4 different rooms for group discussion of cases. At the time of the group discussion, you will be unmuted, and the moderator will present a case for you for brainstorming. So it's then going to be advisable that you nominate a member of the group to reflect in the case of with Professor Sarar later at the main meeting area, because he will come back and it will take around 10 minutes to discuss each case. There is going to be a poll at the start and repeated towards the end of the activity. So please participate. It's going to be anonymous participation by voting. The same poll is going to be run at the start and at the end of the meeting. There are a few housekeeping points here. As mentioned, this meeting is streamed live on FRCPCH Facebook page at the moment, and recorded into FRCPCH media platform, which is like the website, the Facebook group, and YouTube and other platforms. We will email you with the feedback form, as well as that we're going to put the feedback form in the chat box at the end. So everyone, should fill this and submit it. And I appreciate if your thoughts about the events. Feel free to suggest topics for future activities and any suggestions. And as you know, CBD certificates are linked to the feedback as a prerequisite. So you need to write your feedback and send it to us. Then you'll be able to get your certificate. The feedback form is going to be open and active for 1 week, and after that we'll close the feedback form and send you your certificate. I would like to thank you again for attending, and I hope that this activity is going to be an excellent exercise, refreshing our memories about pediatric metabolic emergencies. And as well, I would like to ask you as well check for our activities and for the next activities in the pediatric emergency medicine. And now I leave the floor to Dr. Rihab, to the moderator, the main moderator for the group, to present Professor Sarar. Thank you.
Thank you, Osama. Assalamu alaikum. Good evening, everybody, and greetings to all of you. Thank you for being with us. And I am so pleased to be here tonight and to have the chance to introduce our guest speaker, Professor Sarar Mohamed, who is one of the pioneers in the field of metabolic medicine. Prof. Sarar graduated from the University of Khartoum and then did his MD in pediatrics there. He was then awarded the Diploma of Child Health, MRCPCH, MRCP, FRCPCH, CCST, and the Certificate of Specialist Training Fellowship in Pediatric Metabolic Medicine from the National Center for Metabolic Disorders in Dublin, Ireland. He is also a member of the Royal College of Pediatrics and Child Health UK, and he's a member of the Society for the Study of Inborn Error of Metabolism in UK, as well as the Society for the Study of Inborn Error of Metabolism Middle East, and a member of the Saudi Genetic Society. He has been working as a consultant in pediatrics and metabolic disease for over 15 years now, and currently he is a professor and consultant metabolic pediatrician in Prince Sultan Military Medical City, Riyadh, Saudi Arabia. Prof. Sarar was distinguished from his early years in medical school, where he was awarded a couple of prizes. He has a lot of work in research and a huge number of publications. He's an examiner for the MRCPCH exams, Arab Board in Pediatrics, and for the Saudi Pediatric Endocrine Fellowship. He also has written a book on newborn screening disorders and metabolic emergency. We are honored to have you with us, Prof. Sarar. You have 45 minutes to tell us about the recognition and management of acute metabolic emergencies. Please allow me to remind you 10 minutes prior to the end of your time. For the audience, we do have allocated time for questions following this presentation. Please feel free to post your questions into the chat box, and we will try to answer as much as possible. Prof. Sarar, the mic is yours, but just before Prof. Sarar starts, we want everybody to answer these pre-course questions, which will appear now as a poll.
We'll give you another 15 seconds for the poll, and then we'll close the poll. I don't see many answers, so people please try to answer as much as you can, because I don't see many. I'll extend it to 2 minutes. I have only 4 answers, 5 answers, 6 answers, not much. We have 49 participants at the moment, so expect more. Okay, poll is ending soon. Okay, so the poll has ended. So the first question, 4 years presented with tachypnea, lethargy, and poor feeding. The initial results showed normal blood gas and glucose ammonia 600. So most likely diagnosis, and 73% said urea cycle defect. Second question was, test is likely to suggest the diagnosis of the above. So people are split here. People, they are saying 45% urine organic acids and serum amino acids 45%. What the initial step, best step in the treatment of hyperammonemia, 32%, so bolus of sodium benzoate and sodium phenyl butyrate over 1 to 2 hours. And 32% said bolus of sodium benzoate, sodium phenyl butyrate, and arginine over 1 to 2 hours. And then 4 hours after starting the ammonia scavengers, the ammonia level was 550, most effective treatment, and the majority said hemodialysis, 68%. Okay, Professor Sarar, you can.
Okay, Bismillah, Alhamdulillah, wa salatu wassalamu ala Rasulillah. Thank you very much for inviting me. I'm really excited, and you remind me with my old days in Dublin and in the UK. So thank you. I'm happy really to be with you this evening. So I'm just trying now to share my slides. Okay, I think that is the one. No. Okay, this one. Okay, great. Okay, great. So can you hear me clearly and can you see my slides now?
Yes, we can. Yes.
Okay, good. Okay, and thank you for the introduction. Thank you very much. Okay, so let us start now. So as Dr. Ahmed and Osama said, we are going to have this seminar in two parts. The first part is going to be just a lecture. It will be around 45 to 50 minutes. And then will be followed by a workshop, which is basically 4 cases. I prepared actually 10 cases, but I have been told by Osama this is too much, so we'll do only 4 cases. And it depends on the time. If there is time, so we can do more. Right, so just about the first part, it's going to be focused on the recognition of metabolic emergencies. And this is through good history taking, examination, and then planning diagnostic workup. And then we'll talk basically about the principle of emergency management of patients with metabolic disorder. Okay, so just to start with, we know that more than 600 inborn error of metabolism exist, and most of these are really rare. However, collectively, they account for significant proportion of sick kids. So when you see a sick child in the ER, especially with unexplained etiology, the likely diagnosis would be metabolic disease. The incidence of metabolic disorders is around 1 in 500 to 1 in 1500. It depends on where the study is done. And these patients, they present either clinically or they may be detected by newborn screening at birth. This paper, just to give you an insight of the incidence of metabolic disorders in Saudi Arabia, it is published last year, and it looked at the newborn screening program, and the collective incidence of this disorder is around 1 in 1100. So if you compare this with the incidence in Germany and the US, it is around 1 in 4,000. So it is more than 4 times the incidence in the incidence in Saudi Arabia is more than 4 times than the incidence in Germany and basically the reason for this is very obvious. That is the incidence of consanguinity is high in this community. It is around 56 to 60%. Okay, the slide is not moving here. Okay, good. Right, so how do they present? I'm going to concentrate in the neonatal period, but I mean in children, it is more or less the same way of presentation. So this, the majority of these patients, they present without symptoms and signs in the first few days of life. And after that, they do present as sick neonate. And you know, this is why I think we need to consider metabolic diseases as you know, major differential diagnosis of sepsis, and we need to do metabolic screening as part of the septic workup. So whenever you think of sepsis, please think of metabolic diseases. We need to have high index of suspicion to diagnose these patients. So how do they present? Well, especially in the neonatal period, they present in one of 4 ways. Either they present with acute encephalopathy, and this is due to intoxication with toxic substance like ammonia in urea cycle disorder, or leucine in maple syrup urine disease, or organic acid in organic acidemia, or galactose in galactosemia. So this is one of the major presentation of inborn error of metabolism in the neonatal period and later in childhood as well. The other way of presentation is epileptic encephalopathy, and here they present with intractable seizure or patients may present with energy insufficiency, severe recurrent hypoglycemia or lactic acidosis, or maybe they present simply with metabolic acidosis. The other way of presentation is cardiac, and they do present with cardiomyopathy. Some of them, they present with arrhythmias, especially fatty acid oxidation disorder. So all in all, they present either as acute encephalopathy, epileptic encephalopathy, energy insufficiency, or they present with cardiac manifestation. So we need to keep an eye on this presentation. Right, so just regarding the first way of presentation, that is acute encephalopathy. Babies usually they present with symptoms-free period, and then they develop poor feeding, vomiting, lethargy, seizure, and then they can go into coma. And here in this, the differential diagnosis of this group of acute encephalopathy is urea cycle disorder. This is major differential diagnosis, organic aciduria, maple syrup urine disease, and galactosemia. So whenever you see a patient presenting with acute encephalopathy, please consider these disorders. Okay, the second way of presentation is epileptic encephalopathy, and here the predominant presentation is seizure, and usually it is intractable seizure. And top on the list of the causes of epileptic encephalopathy, especially in infancy, is non-ketotic hyperglycemia. However, other rare causes are sulfite oxidase, deficiency of molybdenum cofactor deficiency, and other like neurotransmitter disorder, peroxisomal disorder. And here is a list of causes of epileptic encephalopathy we need to remember. I'm not going to go into details here because of the time. Right, so the third way of presentation is cardiac, and here comes fatty acid oxidation disorder, especially MCAD and VLCAD. VLCAD can be present in the neonatal period, but MCAD usually presents later on. Primary carnitine deficiency also can present with cardiac presentation. And we need also to consider glycogen storage disease type 2, Pompe, which may present with respiratory failure and with cardiomyopathy as well. So the last way of presentation of metabolic disorder is energy insufficiency, and here basically the presentation is hypoglycemia and or lactic acidosis. So if the presentation is in day 1, we need to consider hyperinsulinism. Hyperinsulinism usually presents in the first day of life with severe persistent hypoglycemia. However, we need to consider other disorder. Usually they do present a little bit later on, usually not in the first day of life, like glycogen storage disease and fatty acid oxidation disorder. Lactic acidosis usually is a manifestation of mitochondria disorder. So we need to consider that whenever we have patient with persistent lactic acidosis. Other causes like pyruvate metabolism disorder, pyruvate dehydrogenase, or pyruvate carboxylase. Right, so these are the way of presentation and the differential diagnosis. We need really to take good history when we suspect metabolic disorder. And first of all, you need to start with prenatal history, and you need to ask the mother about HELP syndrome, that is low platelets and high liver enzyme and hemolysis. So hemolysis, elevated liver enzymes, and low platelets during pregnancy, and this might indicate fatty acid oxidation disorder. Age of presentation is very useful here to pinpoint the diagnosis. So if the presentation is very early in the first few hours of life, you need to consider hyperinsulinism, especially if the patient presenting with severe persistent hypoglycemia. Patients presenting with symptoms-free period, like in the first day and second day, then presenting with symptoms like vomiting, poor feeding, lethargy, and so on, we need to consider the first group we spoke about, that is acute encephalopathy. And here, top of the list is maple syrup urine disease, urea cycle disorder, and organic acidemia. Galactosemia usually presents towards the end of the first week. However, they may present earlier on. And if you suspect galactosemia, you need to examine the eye for the presence of cataract. Right, so we need to put things in perspective. So the way of presentation might give you good clue. And as I said, if there is no symptoms in the first day of life and then symptoms come after that, we need to consider acute encephalopathy. Right, important points in the history, including the newborn screening. So we need to ask about the result of newborn screening. And here, you know, I know that in UK, most of or all patients or all babies are screened, but they are screened for a limited number of disorders. So whenever you see a patient with metabolic disorder, you need to look into the result of the newborn screening. History of prolonged jaundice might suggest galactosemia or tyrosinemia or generally metabolic liver disease, especially if there is bleeding tendency. Okay, you need to use not only your eyes, but you need to use your nose as well. So if there is any abnormal odor, you know, this might suggest metabolic disorder, and these are some examples of abnormal odor which are sometimes diagnostic actually, you know. So if you see a child with sweaty feet, this might suggest cholestatic aciduria type 1, type 2, or isovaleric aciduria. As all of us know, maple syrup odor is suggestive of maple syrup urine disease. And if there is odor of boiled cabbage, this might suggest increased methionine in the blood. And the typical example here is tyrosinemia. Untreated, missed patients with phenylketonuria might have the odor of mousy or musty odor. If you see a patient with rotten fish odor, then you need to think of trimethylamine. So use your nose as well as your eyes. Also very important to ask about the history of consanguinity, especially in the Middle East. And this might suggest, you know, the risk of metabolic diseases is high. History of SIDS might suggest fatty acid oxidation disorder in the family, or history of unexplained neonatal death, or another infant or child with developmental delay, premature death also might suggest, you know, something like hyperlipidemia. Okay, very, very important for the trainee to draw 3-generation family pedigree, especially in areas where consanguinity is high. Okay, then examination is important, and you know, if the patient presents sick looking and there is no obvious cause for the disease, then the possibility of metabolic disorder should be there. We need to assess the growth and you know, look at the dysmorphic feature. Examination of the eyes, very important to rule out possibility of galactosemia, especially if there is cataract. Examination of the abdomen for hepatosplenomegaly. If there is liver palpable, then glycogen storage disease would be high on the list. If there is hypoglycemia as well. If there is liver impairment with hepatomegaly, then one would think of galactosemia as well as tyrosinemia. Patients with hypotonia, we need to think about the acute encephalopathy, as I mentioned earlier on. And if there is a large heart, then the possibility of fatty acid oxidation defect would be high on the list. Examination of the skin for bruises, which might indicate liver dysfunction. Right, this is an example of a patient presented on day 7 with cataract, and the diagnosis here was galactosemia. And by the way, cataract can present as early as the first day of life. Right, so that is the history and examination. And then we need to proceed to plan our investigations. And it is really simple here to plan the investigations if you suspect metabolic disorder. And here I put them in 3 categories. The initial investigation, which can be done at the level of the ER. So things like full blood count or complete blood count, renal function and liver functions are very important. Glucose and lactate and blood gas is really crucial, you know, and when you do blood gas, you need to calculate the anion gap. And I heard from Osama, he presented the, you know, how to approach metabolic disorder, especially with metabolic acidosis. So I'm not going to go into details here, but you know, anion gap is really important. Okay, in the emergency room, you need to check your ammonia. Whenever you have sick baby or sick infant or even sick child with unexplained diagnosis, ammonia should be done. Of course, septic workup is important, and CRP is as well. Urine for ketones, very, very important bedside test, very informative. Any sick baby or sick child should have this test done at the level of the emergency room. And by the way, newborn babies should not excrete ketones. So if you find positive ketones in a newborn baby, this baby is probably using an alternative pathway. And here you think of metabolic disorder, things like organic aciduria and maple syrup urine disease. Urine for reducing substance might suggest galactosemia. However, this is not all the time. So some of patients with galactosemia might have normal urine without reducing substances. So this is the first line of investigations that need to be done for any sick baby, especially if you think of metabolic disorder. Right. So here just a little look at the hypoglycemia workup, and I'm sure you are familiar with critical samples. So whenever you have patients with hypoglycemia, especially if it is persistent hypoglycemia, if it is significant, and you know the definition is different from hospital to hospital, but generally speaking, any patient with blood sugar of less than 2.7 or 2.5, you need to do critical samples, and this is the critical samples usually we do. Some hormones like cortisol, growth hormone, and insulin, and we need to do amino acid and acyl carnitine profile. Ammonia, of course, is important, and ketones and blood gas. So these are the critical samples for hypoglycemia. So what are the causes of hypoglycemia when you have a patient with significant hypoglycemia? You can classify them into 2, ketotic and non-ketotic. And I better start with non-ketotic because the causes are really limited. So if you have patients with hypoglycemia and no ketones, you need to think of hyperinsulinism as one of the major differential diagnoses. And then fatty acid oxidation disorder, carnitine deficiency, and defect in the formation of ketone bodies, or what we call ketogenesis defect. Other than this, hypoglycemia usually is ketotic, and all other hormones, they cause ketotic hypoglycemia, and almost all other metabolic disorder like glycogen storage disease, mitochondria, and so on, all of them, they do present with ketotic hypoglycemia. Right, so critical samples important here. I'm just going to touch on metabolic acidosis, and you know, because it is really important to calculate your anion gap. So if the anion gap is normal, then you think of renal cause or GI. If the anion gap is increased, then the likely diagnosis is metabolic disorder. Okay, so you need to ask yourself what could be the cause. And if the anion gap is increased, it is basically due to accumulation of an acid. So you ask yourself, what acid is it? So the acid can be lactic acid, and this is suggestive of mitochondrial disorder, or can be organic acid, suggestive of organic aciduria, or can be keto acid, which is suggestive again of organic acidemia and ketolytic disorder. So whenever you do blood gas, calculate the anion gap and use this lactic acid, organic acid, and keto acid to explain the increased anion gap. Right, okay, so this is just to touch on the hyperammonemia, and if you have a patient with hyperammonemia, what could be the causes, because this is a common scenario. Urea cycle disorder is a leading cause of hyperammonemia, and typically in urea cycle disorder, the blood gas is normal, or sometimes you might see respiratory alkalosis. This is very important clinical sign to suggest urea cycle disorder. So hyperammonemia in the presence of respiratory alkalosis is highly suggestive of urea cycle disorder. And the reason for this, because ammonia is stimulant to the respiratory center, and this will induce respiratory alkalosis. Sick patient with hyperammonemia, respiratory alkalosis, please think of urea cycle disorder. What is the differential diagnosis? Well, organic acidemia can present with hyperammonemia, but usually it is associated with metabolic acidosis. Hyperammonemia can be a manifestation of many metabolic disorder, but usually it is secondary hyperammonemia due to suppression of the urea cycle. And the typical examples here are mitochondrial disorder, fatty acid oxidation disorder, and maple syrup urine disease. So if you have a patient with hyperammonemia, think of urea cycle disorder if the blood gas is normal or there is respiratory alkalosis. If there is acidosis with hyperammonemia, then the diagnosis usually is organic acidemia or maple syrup urine disease. Okay, right, so that is the first line of investigation. What about the second line? Well, if you really think of metabolic diseases here as a cause of emergencies, then you need to take blood for amino acid, acyl carnitine profile, and urine organic acid. These are very informative tests, and usually they are diagnostic. In urea cycle disorder, amino acid is usually diagnostic. Usually we see increased glutamine and low arginine. Acyl carnitine profile usually is diagnostic in organic acidemia, so you see some abnormal acyl carnitine, like you see propanol carnitine in methylmalonic and propionic aciduria. Organic acid also is important, and succinyl acetone is a marker for tyrosinemia, as you know. Okay, if you suspect galactosemia, then you need to assay the enzyme galactose phosphate uridyl transferase. Right, this is the machine we use to measure the amino acid and the acyl carnitine. It is tandem mass spect. It is really expensive, but it is very useful. Right, so just to give you an idea about the acyl carnitine, what is it? Acyl carnitine is basically, it is a conjugate of organic acid and carnitine. And it is increased in disorder of fatty acid and disorder of amino acid. So whenever you have this, then you need to measure your acyl carnitine. Okay, and this is the how you get the result. You see, the level of this acyl carnitine from C0 to C6, 8, 14, and so on, and you see the level of the amino acid. Okay, so this is an example of a patient with MCAT, medium acylcoenzyme dehydrogenase deficiency, and typically they have increased C8. So if you see this, the diagnosis is MCAT. Right. You don't need to know the details, but you need to know the idea. There is markers for each of the fatty acid oxidation disorder and organic acidemia. So whenever you see these elevated markers, then this would suggest the diagnosis. Right, so what about amino acid? Very important, and there are few conditions where you really need to know what amino acid profile like. For example, if you have high leucine, high isoleucine, and valine, then the diagnosis of maple syrup urine disease would be the way to go. Okay, if the tyrosine is high, then the diagnosis is tyrosinemia. glycine is elevated in non-ketotic hyperglycemia and in organic aciduria. And typically in mitochondrial disorder, you see high alanine. Okay, so it is important to know this, and there are many amino acid disorders, but these are important ones. And not to forget urea cycle disorder, where you see increased glutamine and low arginine, with exception of one disorder, that is arginase deficiency. Okay. Right, so this is a typical profile of different urea cycle disorder with different amino acid profile, but generally speaking, as I mentioned, glutamine is high in all disorder, arginine is low in all disorders, with exception of arginase deficiency. This is a machine we use to measure the organic acid. It is called gas chromatography mass spec, GCMS. And here is the result of normal urine. You just see this graph, and there are metabolites excreted normally in the urine. So if one of them is elevated, this might suggest a diagnosis. Like in this one, for example, if 3-hydroxypropanic acid is increased, this might suggest propanic acidemia or methylmalonic. Right, so just to put things in perspective, you need to put all the results together to suggest the diagnosis. Right, sometimes you need to do other supportive tests to reach a diagnosis. Chest X-ray might be useful, skeletal survey, and echo, ECG, especially if there's cardiac presentation. Abdominal ultrasound, cranial ultrasound. Sometimes we do MRI if we suspect neurometabolic disorder like mitochondrial disorder. And this usually is coupled with MRS spectroscopy. And EEG might be done in some patients. This is an example of a patient with Lee disease, where you see increased signals here in the basal ganglia with increase in lactic acid here in the MRS. Right, so this is we finish with the second line of investigation, and here comes the third line of investigation. Usually we leave this for the specialist. As general pediatrician, you need to consult your specialist in metabolic disorder, and usually if you don't have diagnosis at this stage, then you might need to do CSF for lactate and for amino acid, especially glycine. Lactate pyruvate, we used to do it a lot, but now we don't do a lot of tests for pyruvate and lactate. And then depending on the presentation, then you can be guided. But here, a mutation analysis and genetic study is really important. And now it becomes one of the early tests actually we do after you do your ammonia and amino acid. And if you suspect metabolic disorders, then your second line would be genetic testing. Okay, skin biopsy and muscle biopsy, we moved away from this nowadays in the presence of genetic studies. Okay, so just to put things in perspective, when you need really to take good history, to have high index of suspicion, when you see patients with possible metabolic disease, you need to plan your investigation accordingly. As I mentioned, the first line, second line, and third line, and then you start your management. This is just a quick example of a patient presented with vomiting, on this drowsiness, he had hepatomegaly and bruising. So obviously from this, the possibility of sepsis is there, but the possibility of metabolic liver disease is high. So galactosemia and tyrosinemia need to be ruled out here. Okay, so in this particular patient, urine organic acid was normal, but urine succinyl-acetone was normal or negative, which excluded tyrosinemia, and at the end, enzyme assay was done, and the final diagnosis was galactosemia. And the patient had cataract. A mutation study identified this causative mutation. Another example of a patient presented with hypotonia, lethargy, and coma, and he had intractable seizure. And all this occur in the first day of life. And here you really need to suspect non-ketotic hyperglycemia, and the diagnostic test was the CSF plasma ratio of glycine. Okay, I'm not going to go into details here. I'm just going to go through the principle of management in the coming 5 minutes, just to finish up. And luckily, the principle of management is the same for almost all metabolic disorders. So whenever you suspect metabolic disease, you need just to start with the pillar of management, which are the supportive care. And the other important principle is to reverse the catabolism. And this is simply by providing high calories, and you need to remove the toxic metabolites such as ammonia. So these are really the principle of the management, and it is applied for almost all metabolic disorder. So let us start with supportive management, and here admission to the NICU is really important. So when you suspect metabolic emergency, you need to phone your PICU colleagues and to admit the patient. You need to establish good lines, maybe at least two preferred lines, and maybe central line if possible. If the patient has respiratory compromise, then you need to ventilate that patient. Of course, you need to correct the hypoglycemia, hypothermia. You need to look after the fluid and electrolytes. And if there is cardiac manifestations, then you might need to start inotropes. And very, very important to treat the acidosis. And we use sodium bicarb freely here. You know, if you compare this with diabetic ketoacidosis, where we don't use bicarb, here we use bicarb freely to correct the acidosis. And sometimes we might need to do dialysis if the acidosis is persistent. And if there is evidence of cerebral edema, then you need to treat that. Okay, all patients with possible metabolic disease, we cover them with antibiotics, because here you never know, and sometimes sepsis may be associated with metabolic disease at the same time. Right, so the second principle is to reverse the catabolism, and here by stopping all sorts of protein, because here we are talking about, you know, most of the emergencies are linked to protein metabolism. So whenever you think of metabolic disease, you need to stop the intake of protein, and you need to give high calories. Usually we give something like 150 kilocalorie per kg per day. And we start with glucose, dextrose 10%. If you have central lines, then you might need to go up to 15% and sometimes 20%, and this might lead to hyperglycemia. So if there is hyperglycemia, then you need to start your insulin infusion. Try and keep the blood sugar less than 11 and beta less than 8. Intralipid is very important source of energy, so you can start that, but after you excluded fatty acid oxidation disorder. So exclude fatty acid oxidation disorder, and after that start intralipid. Right, so the third and the last principle is to remove the toxic metabolites. So if there is hyperammonemia, then you need to start the ammonia scavenger medication. And typically, we start sodium benzoate, sodium phenyl butyrate, and arginine. So these are the three medications we start when we have hyperammonemia. And you know, we are lucky in our hospital to have ammonol. Ammonol is a drug that contains both sodium benzoate and sodium phenyl acetate. Okay, so either you start ammonol with arginine, or if you don't have ammonol, then you need to start arginine, sodium phenyl butyrate, and sodium benzoate. Okay, sometimes we start other cofactor if we are not sure about the diagnosis. Things like carnitine, B12, biotin. We just start them very early in the management, and then we'll be directed by the result of the test. If the ammonia is high or if the leucine is high in maple syrup urine disease, then you need to remove that by dialysis. And the best way of removing these metabolites is hemodialysis. And peritoneal dialysis is really useless. However, if you don't have other option, then you might need to start with peritoneal dialysis. And the reason for this, because the clearance rate for peritoneal dialysis is very, very low. Usually it is 6 to 12 ml per minute. And this is compared to hemodialysis, where the clearance rate is 80 to 100. Hemofiltration is in between. Okay, so the best is hemodialysis, and hemofiltration after that. Protein dialysis is the least effective. And nowadays, if you have ECMO, the rate of the clearance rate of ECMO is higher than hemodialysis, so you can start that. Okay, so other medication, we start them directed by the diagnosis. So if you have tyrosinemia, you might need to start NTBC and so on. As I said, sometimes we start patients in...
Sorry, Prof. Sarar, you have 10 minutes more.
Okay, great, good. Okay, so the other principle of management is dietary management, and here it is very simple, because if you have substance A, for example, converted to substance B by an enzyme. So if this enzyme is deficient, then you end with accumulation of substance A and deficiency of substance B. So the principle of dietary management is to restrict A and to supplement B. And this is well known in many of the metabolic disorders. Like in galactosemia, you give galactose-free formula. In urea cycle disorder, you give low protein, and in maple syrup urine disease, you restrict your leucine, and so on. We have many formulas, so we don't need to go into details. Right, so this is just to recapitulate here. If you have a patient with hyperammonemia, you need to start with the general principle, start with ABC, admit to the PICU, establish your peripheral and central line, and start with good hydration, usually 1.5 maintenance of dextrose 10% to 20%, and give high calories, start intralipid when you exclude fatty acid oxidation disorder. And you need to ventilate your patient if the patient is sick, and monitor your electrolytes. So this is a general principle of hyperammonemia management. And then, as I mentioned earlier, if the ammonia is high, if it is more than 150, I would start ammonia scavengers. And again, the best medication you start with are arginine, sodium benzoate, and sodium phenylbutyrate. If the ammonia is high, you need to prepare the scene for dialysis, and usually you start dialysis if the ammonia is more than 400. Okay, and then you start your special formula. Right, so treatment of hyperammonemia is really teamwork. So whenever you have high ammonia, you need to involve your other colleagues, especially the pharmacy, to prepare the medication. You need to also involve your nephrologist to prepare for dialysis, intensive care, and surgical team, if you want to put a catheter, and you need to inform your laboratory to be ready to give you the ammonia result and to check the amino acid and so on. And you need to involve your dietitian. So it is really a teamwork, and you start this from when you see the patient. Okay. Now, here we come to the conclusion, and I think the take-home message here is we need to think of metabolic disorder, or metabolic emergency, whenever we see sick child or sick infant with unexplained acute illness, especially if there is evidence of acute encephalopathy, if there is evidence of impaired liver function, or if there is evidence of cardiomyopathy, intractable seizure, unexplained persistent hypoglycemia, unexplained metabolic acidosis, or when there is hyperammonemia. we need to use our metabolic testing in a rational way, and we need to start with supportive measure. Okay, please consider treatable disorder first. Urea cycle disorder, Mebel urine disease, and organic acidemia, galactosemia should be considered first whenever you think of metabolic emergency. And if you are in doubt, you better ask your colleagues. Thank you very much for listening. I'm happy to take questions.
Okay, thank you very much, Professor Sarar, for this excellent and informative talk. We have enjoyed it very much. Before we take the questions, I would like to welcome whoever joined later on. Thank you very much for your attendance. And on the behalf of FRCPCH, also I would like to welcome Professor Mustafa Saleh, who is with us also today. We are very honored and pleasured with his presence. Prof. Mustafa, if you would like to say anything, or if you have any comments, you are welcome to do so, and I will unmute you. Or maybe Osama, if you can unmute Prof. Saleh, maybe from my side, I couldn't unmute him. Okay.
I think it is really great pleasure to see Professor Saleh attending this activity. It is a pleasure for me as well as for you. He is our teacher, and we learn a lot from him, from the medical school, through the internship, and then, during our training, and then as a colleague and senior colleague in King Saud University. And he really added a lot to the literature with over 400 publications. So it is really a pleasure to see Professor Saleh here.
Okay.
I don't think he's around now at the moment, so I think he's...
Yes.
Okay, that's fine.
Okay, until he comes back, we will start taking questions, Prof. Sarar, if that's okay.
Yeah, sure. Yeah.
So someone is asking about, I would like to ask about the feasibility and reliability of checking ammonia in Sudan labs and how to provide a reliable one.
You ask a very difficult question, yeah, I think, checking ammonia is really important, and I think it should be available at least in the emergency setting. I think it should be available at least in Ja'far ibn Auf Hospital, in Soba University Hospital, and in Durman. So this is very, very, very important, and it is not a difficult test, and I remember we used to do it in the Department of Biochemistry in Faculty of Medicine in Khartoum, like 25 years ago. So I think we should be able to do it. And I know nowadays there are some labs can do it, Al-Buruj, for example, and I heard about other labs. So I think it is very, really, really important to have this facility and to check the ammonia whenever you see a sick child with possible metabolic disorder. And down the line, I think in the coming few years, we are going to see a bit site ammonia testing, and I think if this materializes, it's going to be very useful for the low resource countries like Sudan.
Okay. Thank you, Professor Sarar. The other question is from Iman. What is the reason behind the age variability in presentation of inborn error of metabolism?
Yeah, basically it depends on the disease. It depends on the pathophysiology. For example, if you take hyperinsulinism, hyperinsulinism is an endocrine disorder, but there are some metabolic disorders associated with hyperinsulinism as well. So here the presentation is very early because the insulin is going to give you hyperglycemia, and it is usually persistent. So the presentation is really early. For example, non-ketotic hyperglycinemia, presents very early with intractable seizure because, the glycine is high in the CSF. For other conditions like urea cycle disorder and organic acidemia, you need to have some protein on board. So usually in day one, the baby is normal. So whenever the baby start to have protein like milk and breastfeeding, then the amino acid is going to accumulate, and this will lead to increase in the ammonia and in other features of decompensation. So this disorder usually they present around day 2 or 3 after starting the milk. And it is the same theory for galactosemia. You need to have some milk on board, to have some galactose on board, and this will lead to the manifestation of the disease.
Okay, thanks. The next question says, how can we tailor metabolic investigations in our current resource-limited situation in Sudan?
Okay, again, yeah, I hope we will be able to do at least the important investigations. And I think just to start with, blood gas machine, I think should be available in all emergency settings. So this is really important. The second thing is urine ketones. I don't think this is difficult to do nowadays, and you can use a DB stick to check for ketones. I think this is another thing we really need to have in the emergency setting. And then checking the ammonia. I think if you can do these 3, you would be able to diagnose most of the metabolic emergencies, especially in the neonatal period. And then after that, the rest would come later on, and then when you have all the clinical features and you have the result of all this, then you can take it from there.
Okay, the next question is about the prognosis of urea cycle defect. Someone is asking, what is the prognosis of urea cycle defect?
Sure, yeah, that is a good question, and it depends. It depends on your setting, and it depends on the time of presentation. For example, in Saudi Arabia now we screen for 2 disorders of the urea cycle. As there are 6 enzymes in the urea cycle. So we screen for 2 of them, adenosuccinic aciduria and citrullinemia. So if you diagnose these patients early, you can do something about it. So you can treat metabolic decompensation early, and you start your formula and so on. And there is also other viable option actually nowadays for urea cycle disorder, which is liver transplant. And we transplanted many patients with urea cycle, and they are doing fine. So it depends, but generally speaking, most of the patients you would end with neurological deficit. So more than, I would say, 50 to 60 from the literature would end with neurological deficit. And, maybe 25 to 30%, they usually die early in infancy. But nowadays, the prognosis has improved. With newborn screening, with the availability of medication, with the availability of dialysis, and with availability of organ transplant.
Okay, another question says, can we go for exchange transfusion instead of hemodialysis if no facilities for the later?
I'm glad you mentioned this, and there is no place for exchange transfusion at all. Here you are talking about small molecules, about the ammonia, so exchange transfusion is not going to decrease the ammonia level. So peritoneal dialysis is not really good, but it is something you can do if you don't have a facility to do hemodialysis.
Okay, thank you. Another one says, thank you very much for this nice presentation. I have one patient who is known case of mitochondrial disease. ATPase deficiency present by vomiting. How can I treat patient like this? What is this? Is metabolic acidosis.
Okay, well, I mean, mitochondrial disease treatment is really supportive, you know, and, you know, I'm glad you mentioned this because, you know, in the acute emergency, when you have mitochondrial disorder, we don't give high dextrose. This is very, very important. So you give 5% dextrose instead of 10%. And the reason for this, because if you give high dextrose, you are going to stimulate your glycolysis pathway, and this will end with increased pyruvate, and pyruvate is going to be converted to lactate. So you will increase the lactic acid in the blood. So one of the important things in the management of emergencies in mitochondrial disease is not to give high dextrose. 5% dextrose is quite enough. You can give intralipid, okay, to maximize your calories. And then sometimes we start cocktails like, you know, biotin, thiamine, coenzyme Q, and so on. But it is really important to monitor your electrolytes and the blood gas and to treat the acidosis, you know, and, you know, just not to give high dextrose. Sometimes mitochondrial disease may be associated with hyperammonemia, so we treat hyperammonemia as in urea cycle disorder. So if the ammonia is high, we need to start ammonia scavengers. If it is very, very high, then you might need to do dialysis as well.
Between hereditary fructose intolerance and fructose 1,6 biphosphatase.
I couldn't hear the first part of the question, but, you know, if you mention fructose 1,6 biphosphatase, yes, it is one of the major causes of hypoglycemia, and usually they have severe metabolic acidosis. So we need to suspect this disorder whenever we see a patient with persistent hypoglycemia and severe metabolic acidosis. I have like 15 patients with fructose 1,6 biphosphatase. They do very well when you start the IV dextrose, and usually the acidosis is corrected, you know, easily when you start your fluid management and sodium bicarb.
Okay, thank you. Start with dextrose 5% in severe decompensation and dextrose 10% in moderate decompensation.
Well, you know, as I mentioned, in almost all metabolic emergencies, we tend to give dextrose at least 10%. Okay, like in urea cycle disorder, in organic acidemias, and in methylcerebrorin disease, and so on. The only exception is mitochondrial disorder, where you need to use 5% dextrose. So, you know, try to use 10% all the time, with exception of mitochondrial disorder.
Are there conditions other than mitochondrial disease where we need to avoid high dextrose concentrations?
Really, you know, most of the other conditions, or almost all, you really need to give high dextrose, because, you know, the metabolism of glucose is the way to go. The access to the brain is easy, and so on. So we really need to, you know, use low dextrose only when we suspect mitochondrial disorder.
What is the best formula to start feeding after management? And what is the max protein to introduce till diagnosis is certain?
Sorry, I can't hear you. Can you repeat the question again?
I will repeat the question. There is 2 parts in this question. It says, what is the best formula to start feeding after management of hyperammonemia? And what is the maximum protein to introduce till diagnosis is certain?
Okay, these are good questions, and
Yes,
they are
very nice questions.
Yeah, I mean the formula for urea cycle disorder is called cyclin-X. Okay, and cyclin-X is basically you avoid some of the amino acid. So this is the formula we use for urea cycle disorder. Okay, if you don't know the diagnosis, because sometimes you work in the dark, okay, the first thing you do, you stop all the sources of protein, you give high calories. When you exclude fat acid oxidation defects, then you need to start intralipid. Okay, and then you need to introduce your protein gradually. And usually we start by 0.5 gram per kg per day. Okay, and we try not to stop the protein for more than 48 hours to maximum of 72 hours. And the reason for this, because if you stop giving the patient protein, the patient is going to use his or her own protein, from the muscles. So this will lead to more catabolism, more accumulation of the ammonia or leucine in maple syrup urine disease, for example. So the message is, you stop the protein intake if you suspect this disorder, okay? And then you reintroduce protein within 48 to 72 hours. Otherwise, you will be ending with catabolism. And the best formula is cyclin-X. I hope I answered your question.
Thank you very much. So this is the last question, and after that we'll go for a break and the workshop. So the last question says, in pyruvate dehydrogenase complex, can we give dextrose 10% or more?
Yeah, it is the same theory, because in pyruvate dehydrogenase, you cannot convert your pyruvate into acetyl-CoA. Okay, so if you give high dextrose, you stimulate the glycolysis, okay, and you end with more accumulation of pyruvate, and this pyruvate will be shunted towards formation of lactate. So you end with lactic acidosis, and this is the thing you don't really need. Okay, so the best for pyruvate dehydrogenase is to give 5% dextrose, not 10% dextrose. Okay, I can see my friend Dr. Mohamed Adam Al-Tayyib is raising his hand, so can you give him just to maybe comment and to see him? Dr. Mohamed Adam, can you unmute him, please?
We'll try to find him. Mohamed Adam, can you raise your hand again?
If you don't,
if you can raise your hand again.
Yeah.
So I can find you.
Okay, here you go.
Okay.
He raised his hand.
You can unmute Mohamed Adam. Go ahead.
يا بروف السلام عليكم يا
مرحبا محمد، كيف حالك؟
والله سعيد يا اخي بانه شفناك يا اخي، و very nice presentation يعني as usual يعني. فانت راجل طبعا ما شاء الله مدهشنا من الجامعه يعني بابداعاتك يعني ما شاء الله يعني. فبرزنتيشن جميل والله يا اخي، كتر خيركم وكتر خير الجمعيه اللي استضافتك يعني. الحقيقه مثلا داير اشوف يعني داير اشوف الرول بتاعكم شنو يا بروف في السودان بالنسبه لاستابليشنج يعني a new metabolic يعني سنتر ولا حاجه زي دي في السودان، وكيف الناس تقدر تعملوا يعني مع بعض كده بتعداد. والله يعني فعلا محتاجين لخبراتكم ومحتاجين للميتابوليك ديزيز، لانها في السودان طبعا بالظروف الصعبه دي يعني محتاجين انه تستابلش السنتر ولا حاجه. فما عارف ان شاء الله يكون عندك لينك بين ناس السودان في انه كيف الناس تقدر تساعدهم وكده. واشكرك بحراره يا اخي مره ثانيه، وان شاء الله نتلاقى قريب.
Thank you, Mohammed. I'm really glad to hear you and to see you as well. By the way, you're there, so you can see you. Okay, yeah. I mean, we try to do our best. you know, and as you know, metabolic disorders are important, but it's not the priority as always. It is not, but I think people can start from scratch and at least to provide, you know, some diagnostic resources, you know, and there is good active group in Sudan. They are working in this, especially Dr. Asmahan. She's, you know, we have a metabolic group with Dr. Mohamed Osman, Asmahan, Dr. Hind, and Dr. Rihab. So we are trying to do something, you know, but as you know, it is really, really difficult. So if we can start with basic things like, you know, checking the ammonia and, you know, if we can have some access to some lab outside to do some genetic testing and so on, that would be the way to go. You know, because sometimes you would like to really prevent the recurrence of metabolic disorder in the future generation, you know. So if you have someone presented very sick and likely to die, you know, you better confirm the diagnosis in that index and try to prevent the recurrence of disease in the future. I think that strategy, you know, is really, you know, good for low resource country. So diagnosis of the index and prevention of the future. And the other thing, I think we really need to start newborn screening, not for all metabolic disorder, but there are some of them, you know, and, you know, which can easily be treated, you know. Something like galactosemia, for example, and it can be treated by lactose-free formula. It is available everywhere. You know, biotinidase deficiency can be treated by biotin. It is tablet. It is available. It is very cheap thing. And also TSH for hypothyroidism. Treatment is only thyroxine. So this disorder, you know, you can select your panel. You don't really need to go into like adding maple syrup urine disease and organic acidemia into your panel if you don't have the resources. But you can start with something like you know, hypothyroidism screening plus biotinidase plus you know, galactosemia plus carnitine deficiency plus congenital adrenal hyperplasia, because the steroids are available everywhere. So it is something you can start with and start with, you know, the resources available. Thank you very much for the question, Mohamed.
Okay, so thank you very much, Prof. Sarar, for answering all our questions. I think they were all very clear. I think now it's time to go for a 5 minutes break, and then we will be back for the workshop. We are around 15 minutes late from our program. So please allow these 15 minutes whenever you look at the program. So it is 6:25. We will be back at 6:30. Okay. During the break, we will have a video if you want to have a look, or if you want to go for grab a cup of coffee or tea. And then after that, you will find yourself in one of the 4 break rooms. And then our moderators will guide you further. Okay, so see you back after 5 minutes.
الشوق عيال كلك ذوق الشوق يا الكلك ذوق مرسال الشوق يا الكلك ذوق عغش الحبان في كل مكان طوف بالحبان في كل مكان قول ليهم شفنا جبل مرة وعشنا اللحظات حب ومسرة قول ليهم شفنا جبل مرة وعشنا اللحظات حب ومسرة وفينا غينا تغازل كل زهرة وخيال رمانة مرسال الشوق فنان تمحى الأحزان لوحة فنان تمحى الأحزان صفرة وحمرة زرقة وخضرة صفرة وحمرة زرقة وخضرة وزحفة نضرة وزحفة ألوان تغازل كل زهرة وخيال رمانة مرسال الشوق
Hello and welcome back. So now what's going to happen after the 5 minutes break and after the lecture is we'll have the break room. So all the people here, 76 participants at the moment, they are going to be divided into 4 groups. And in these 4 groups, they will be given one case by a moderator. They should be discussing this case among themselves and nominate one to come back to the main group again to present to Professor Sarar. People, I just would like to remind people in Facebook that they will not be able to join in the break room. So they're going to be in the main room. And so they should be waiting for around 10 minutes for the break room to finish. And then after that, they can join. Everyone here is able to unmute him or herself during the break room, so you can speak freely. See you in the break room, and if we can please have the break room started. While everyone is in the break room, what I'm going to do, have we started the break room, Habab?
Yes, it has been started. Please just make sure everyone to accept the invitation to the assigned breakout room, please.
There are still 22 unassigned in the breakout room. So please put yourself in one of these, accept the invitation and put yourself in the break room so we can start. Okay, that's great. So everyone is in the breakout room, and we are going to share just for people who are in Facebook, just the poster of the program for today, so they can have a look at it.
نحن أسود الغاب أبناء الحروب لا نهاب الموت أو نخشى الخطوب نحفظ السودان في هذه القلوب نفتدي من شمال أو جنوب بالكفاح المر والعزم المتين وقلوب من حديد لا تلين نهزم الشر ونجلي الغاصبين كنسور الجو أو أسد العرين ندفع الردى نصد من عدا ندفع الردى نصد من عدا نحن جند الله جند الوطن إن دعا داعي الفداء لم نخن نتحدى الموت عند المحن نشتري المجد بأغلى ثمن هذه الأرض لنا فليعش سوداننا علما بين الأمم يا بني السودان هذا رمزكم يحمل العبء ويحمي أرضكم.
So for those who are watching in the Facebook, unfortunately, as I said, you cannot join the break rooms. So I'm just explaining to you what's happening now. That we have around 80 participants, and these 80 participants have been entered into 4 rooms, and in these rooms they have a case, they are discussing it. So then they will come back after 10 minutes and be joined the main group. So now I leave you with the poster.
Prof. Sarar, are you around? All the participants are about to come back in a few seconds. Prof. Sarar?
Yes, yes.
Okay. Everybody will be back soon. Just wanted to make sure you are there.
Can I share my screen?
Yes, Osama, please, if you stop the...
Okay. If everyone is back now?
Yes, they are. Breakout rooms are closed now.
Okay. Was it successful?
حاضر أمونة لو ما مشينا ربنا.
Okay, can we start?
Yes, sure, please, go ahead.
So we start with case 1. You know, as I mentioned earlier, I prepared many cases actually, but we'll try the first 4 and see how it goes. Okay, if we have time, then we can go for some. But we are already late, so let us concentrate on 4 cases. All of them are real life cases, and you know, so start with case 1. So who's the speaker for the first room?
Speaker for the first room, please raise the hand so we can let you unmute yourself.
This will be Dr. Hind Ahmed.
So, Dr. Hind, please raise your hand.
Okay, so let us start. Okay, let me read it for you. Okay, so this is 3 days old term boy delivered by uneventful pregnancy. He was apparently well and sent home in 24 hours. However, the baby came back on day 3 lethargic with vomiting, poor sucking, and seizure. On examination, he was lethargic, hypotonic, he has no dysmorphic features, he was tachypnic, respiratory rate was 90 per minute, he had features of respiratory distress, his blood pressure was normal, his pulse was normal, and his heart examination was normal. Abdomen, there is no organomegaly, and genitalia was normal. So, what is the likely diagnosis? Can you vote? Can everybody vote first, please?
Okay, I'll bring the
Go
poll.
back to the case here. So it is basically 3 days. Came with vomiting, lethargy, poor feeding. Examination, he was sick and he was hypotonic and he had tachypnea. Okay, so what is the diagnosis? Is it sepsis, cardiac disease, metabolic disease, pneumonia? So you can put more than one answer.
Yeah, so this is a multiple choice question. When it says multiple choice question, that's it. Then you can put more than one answer. When it's single choice question, you're only allowed for one. I'll leave another 15 seconds for the poll, and then I will end the poll. There is a poll there, so please vote in the poll. Okay, so I'm ending the poll now, and I will share the
Very
results.
good. Yeah, so I think the results are really good. Okay, and you know, pneumonia is excluded. You know, only 15% they went for pneumonia, and you know, obviously the scenario cannot be explained by pneumonia. Okay, and sepsis, yes, I would go for sepsis as the first diagnosis, treatable disease, quite common. Okay, then cardiac disease, yes, can present like this, especially the obstructive cardiac lesions. And then you consider metabolic disease. Okay, so differential diagnosis, sepsis, cardiac disease, and metabolic disease. Okay, so then you ask yourself, what metabolic disease? And after this 45 minutes talk, you know, we need to go into details. What could be the metabolic disease here in this newborn baby? So now you can vote. Is it urea cycle disorder, maple syrup urine disease, organic acidemia, or MCAD?
Okay, this is as well a multiple choice question. You can choose more than one answer. So please vote.
Yes,
and I'll... absolutely.
You can choose more than one answer, yeah.
So give you another 10 seconds to end the poll and share the result. Okay, poll is ending now.
Excellent. So 78% voted for urea cycle disorder, which is really good. So this is basically, it is acute encephalopathy presentation. And as I mentioned in the lecture, the top differential diagnosis would be urea cycle disorder, maple syrup urine disease, and organic acidemia. MCAD doesn't present like this. Usually it presents later on and can present with SIDS-like or can present with hypoglycemia, but usually not acute encephalopathy in the first few days of life. Okay. Right. So that is the answer. Urea cycle, maple syrup urine disease, and organic acidemia. So what investigations would you do? Okay, you know, as I mentioned again in the lecture, you start with your first line. You start with CBC, blood gas, glucose, blood culture, urine analysis for ketones, ammonia, lactate, and tandem MS for amino acid, acyl carnitine, and urine organic acid. So let us see what are the results here. Okay, this is a chest X-ray. So can you comment, the speaker? What do you think of this X-ray?
There is no one. Hint was supposed to raise her hand, but she's not around. She's not raising her hand. So just go ahead, please.
Okay, so I guess it is normal. X-ray is normal. Okay, so this baby was admitted to the NICU, started on ampicillin and cefotaxime, and started on mechanical ventilation. His blood gas showed respiratory alkalosis. Okay, and echo was normal, so that excluded cardiac disorder. And the other investigations were normal, except ammonia was 911. Okay, so this baby had respiratory alkalosis and ammonia of 911. So what would be the cause? What is the likely diagnosis? Here we need one answer. Okay, so can you vote now for one condition? Is it urea cycle? Is it methylmalonic, organic, or is it MSUD?
Okay, so the poll is up, and this is a single answer question, so it's not. So you can only choose one. And I see that. I don't want to say it. Hint is hint. You can is around now. So she. And the next question, hint you can. So I'll end the poll in 5 seconds. Okay, and share the result. Share the result. Okay, so poll is ending, and here is the result. So 98% got it right.
For urea cycle disorder, which is great. I think the message passed through. I'm really glad by this, and you know, this is a take-home message. If you have a sick child with respiratory alkalosis and hyperammonemia, the diagnosis is urea cycle disorder. I think one person voted for MSUD, and in MSUD usually there is acidosis. Yes, there is hyperammonemia, but there is acidosis. If you have acidosis and hyperammonemia, the differential diagnosis is MSUD or organic acidemia. Okay, so in this case, it is urea cycle disorder because there is respiratory alkalosis. Very good. Okay, so the likely diagnosis is urea cycle disorder. So how can you differentiate between these disorders?
Hind, do you want to come forward?
Assalamu alaikum. Sorry for being late for the answers, but we go for acyl carnitine profile. It could differentiate between the urea cycle and the rest. And also we do a second step is amino acid to confirm our impression that this urea cycle should show high glutamine, high citrulline, plus or minus, plus low arginine, except in arginine deficiency. So we go for acyl carnitine profile.
Okay, and if I ask you to choose more than one?
If more than one, I will go secondly for amino acids profile.
Okay. Okay. So I think in this scenario, yes, acyl carnitine is important in the diagnosis of organic acidemia, but amino acid is more important for urea cycle. And as I mentioned in the talk, in urea cycle, usually the glutamine is high, the arginine is low, with one exception of arginase deficiency, where the arginine is high. So in urea cycle, all disorder, you see high glutamine and low arginine, with exception of arginine deficiency, where you see high arginine. Okay, acyl carnitine can differentiate between urea cycle and organic acidemia, where you see elevated propanol carnitine, for example, in methyl malonic and so on. And organic acid will diagnose organic aciduria. Urine succinyl acetone is not really needed here because it is a marker for tyrosinemia. Okay, very good. Okay. Right, so regarding the management, what would you do, Hind?
We go first for ABC and we're placing circulation to stabilize the patient. And we stop all source of protein, either oral or parenteral. We give high colors in form of dextrose D10, 15, or 20, according to. And we initiate our ammonia scavenger in form of aminol, arginine, carbaglu. We also inform we let the nephro patient to be on in case the ammonia does not drop after 4 hours, which would initiate hemodialysis. And if we exclude already fatty acid oxidation, we can start lipid in the form of intralipid.
Excellent, excellent comprehensive answer. I have nothing to add. Okay, so you start with supportive care, as she mentioned, and you add intralipid, and then you start your ammonia scavengers, arginine, sodium benzoate, sodium phenyl butyrate. And if the ammonia is high enough, above 400, you start your dialysis. Excellent. So this is a management of hyperammonemia. Okay, and later on you can start your formula. Okay, so just coming back to this baby, we started peritoneal dialysis because the catheter was not available at that time. So the ammonia went down from 911 to 600 and back again to 700 and so on. And here we decided to start hemodialysis. We borrowed the catheter from other hospital, and the ammonia level went down from 825 to 421 in less than 24 hours. And this will show you the difference between peritoneal dialysis and hemodialysis. So in just 24 hours, the ammonia went down nicely. Right, and now the results came back. The patient has
Sorry, Prof. Sarar, you have 3 minutes left for this case. Thanks.
Okay, thank you. Okay, so the serum amino acid showed high citrulline, high glutamine, and low arginine. And the organic acid showed increased uric acid. The acyl carnitine was normal. So what is the diagnosis hint now?
This is could be X-linked ornithine transcarbamylase deficiency, OTC.
Okay, so this could be OTC. In OTC, the citrulline is low, isn't it?
Yeah. The other potential is ASS or ASL, adenosine layers or adenosine synthesis.
So this is the diagnosis. It is either argiosuccinic aciduria or citrullinemia, because the citrulline here is high. Okay, you have high glutamine, low arginine. Okay, So we don't have time to go through all the defects, but the final diagnosis is citrullinemia. Okay, so how do you confirm your diagnosis, and what is your testing strategy?
Mutation analysis or genetic test.
Okay, so what you do? Do you ask for whole exome? Do you ask for a panel, or do you ask for single gene sequencing?
I'll go for single gene sequence.
Exactly. Here you have biochemical diagnosis. You have clinical diagnosis, biochemical diagnosis. You know where the defect is. So here you ask for single gene sequencing, or what we call Sarar sequencing. And the Sarar sequencing confirms the diagnosis here in the ASS gene.
If the tribe is well known, we'll go for target mutation analysis.
Well, the problem with target mutation, yeah, if there is family history, yes, I would go for that. Thank you very much. If you have family history, then you know the mutation in the family, so you just do target mutation. But if you don't, then you need to sequence the whole gene. Right, so the final diagnosis here is citrullinemia. Okay, now we go for case 2. Is there any question about case 1 before going to case 2? So this patient presented with acute encephalopathy. The blood gas was normal initially, then showed respiratory alkalosis. Ammonia was very high. Okay, and the amino acid showed high glutamine, high citrulline, and low arginine. The diagnosis is citrullinemia. Right. Okay, so case 2, who's the speaker? Speaker for the second group.
Hi, Prof. Sarar. I was a moderator of the group, and I'm afraid I don't have a volunteer. Have 2 active members of the group, Fatima and Hiba, but I'm not sure if they want to step forward to take the lead in discussing this case.
Okay, so we take both of them. Okay.
Okay, Fatima and Hiba.
Raise your hand, please. Raise your hand. And go easy on them, Prof.
Well, I mean, this one is a little bit easier. Okay, so this is 5 days old, term boy. Pregnancy was uneventful. He was okay, discharged home, and then came back on day 4, lethargic, with vomiting, with poor feeding, and seizures. He was sick-looking, hypotensive, dehydrated. His cardiovascular system was normal, and specifically, his femoral pulses are intact. Okay, and he had no organomegaly. Right. So what is the diagnosis? So now for everybody to vote. What is the likely diagnosis here? Is it sepsis? You can choose more than one answer. Is it cardiac disease? Is it metabolic? Or is it pneumonia?
So I'll end the poll in 5 seconds and share the results. Okay, poll is ended.
Okay, excellent answers. So possibility of sepsis is there, metabolic disorders, different types of metabolic disorder, and left heart obstructive lesion is there as well. Very good. So pneumonia is unlikely here again. Okay. Now, so second question, what metabolic disease? Is it urea cycle? Is it methylsyruburin disease? Is it organic acidemia or medium chain acycloenzyme dehydrogenase deficiency?
Okay, multiple choice. Vote please. More than one answer. Ending in 5 seconds, and I will share the result. Okay, so here is the result.
Okay, thank you. Very good result. So basically, this is again another case of acute encephalopathy. Differential, as I mentioned, is urea cycle, maple syrup, organic acidemia. MCAD is unlikely, it doesn't present that early. Okay, so we have the lab result here, which is going to differentiate. Okay, so all results were normal except ammonia was 200. And the blood gas showed pH of 7, bicarb of 6, and anion gap of 27, and lactate of 5. and during ketones was positive. So you have ammonia of 200, you have severe metabolic acidosis, and mainly it is ketoacidosis basically. Right. So what is the most likely diagnosis? Here you need to choose one. Is it urea cycle, or is it methylsyruburin disease? Is it organic acidemia, or is it medium chain acyl-CoA dehydrogenase? One choice, please.
So poll is ending now, and I'll share the result.
Okay, very good. So most people, they vote for organic acidemia, which is the case, and 9 people voted for methylsyruburin disease. To be honest, it is difficult to exclude methylsyruburin disease because both of them, they present with ammonia, moderate ammonia, with metabolic acidosis, with ketoacidosis. So difficult, but organic acidemia is more common than methylsyruburin disease. Both answers, I would say, they are okay. Okay. So methylsyruburin disease, organic acidemia. How can you differentiate between the two? Speaker. Mrs. Speaker. How can you differentiate between methylsyruburin disease and organic acidemia?
She's not around. So.
Okay, anyone? Hint, can you answer?
Yes, we can do here specifically acylcarnitine profile and also amino acid profile. Can differentiate between both. If we find that the leucine, isoleucine, and valine is high or very high, this goes with methylsyruburin disease. If we find C3 or propionyl-CoA is high in the acylcarnitine, so maybe propionic or methylmalonic acidemia.
Excellent. So 3 tests, I would say. Serum amino acid in methylsyruburin disease, leucine, isoleucine, and valine are elevated. Okay, and what do you find in organic acidemia in serum amino acid?
High glycine, high alanine.
Excellent. Glycine is usually high, okay? And then to diagnose organic acidemia, you need your organic acid, urine organic acid, and acylcarnitine, okay? Excellent. So how do you manage this patient? Same principle of management, right? So you start with your ABC, admit your patient to the PICU, discontinue protein, give high calories, and start your intralipid. And then you start medication for both maple syrup and organic acidemia. So you start thiamine for methylsyruburin disease and carnitine and biotin for organic acidemia. Now you have the results. The acylcarnitine was high. It is high C3, high propanyl carnitine, and high glycine. So what is the diagnosis? And now it is for everybody, the poll for everybody.
One answer.
So is it MMA? You can choose more than one answer.
Yes, this is
so
multiple choice.
Yeah, it is. Is it MMA? Is it PA? Or is it MSUD?
Until this stage, still we have 2 differential diagnoses, methylmalonic acidemia and propionic acidemia.
Excellent. Okay, so voting is also good, very good actually. So here the differential is differential of organic acidemia, either methylmalonic or propionic. Both of them, they would give you high propanyl carnitine, high C3. So the diagnosis is either MMA or PA. How can you differentiate between these two?
Urine organic acid.
Okay, which is going to show what?
Prof. Sarar, we have 3 minutes more for this case.
Okay, good. Okay, you are right. You are right. Organic acid is going to differentiate.
Yes, both of them, they can show 3-hydroxypropionyl, but the difference is that if we have methylmalonic acidemia, we should see methyl citrate or methylmalonic acid.
Very good. So the differentiating point here is the presence of methylmalonic acid in the urine. If there is methylmalonic acid in the urine, then the diagnosis is methylmalonic. If there isn't, then the diagnosis is propenyl aciduria or propionic aciduria. So here's the methylmalonic. There is methyl citrate and 3-hydroxypropanic acid. So what is the diagnosis?
Propionic acidemia.
Okay, very good. So the diagnosis here is propionic acidemia. Okay, management is same principle. You start with symptomatic management. You admit your patient to the PICU, start with ABCs, give high calories, give intralipid, give glucose. And if the glucose is high, then insulin infusion. Or can you start with carnitine and B12 and biotin, and you give a special formula. It is called Propimix. Excellent. So we move. So how do you confirm your diagnosis? What is your testing strategy? Would you do whole exome? Would you do gene panel or single gene?
Single gene, BCCA or BCCP.
Very good. So here we have two genes that can cause propionic acidemia, PCCA and PCCB. So you can assay both of them, or you can sequence both of them. So here the final diagnosis is propionic, and treatment is basically by giving special formula, carnitine and biotin. Excellent. So we can move to case 3. Right. Speaker for group 3.
Iman?
Yeah, it is enough for hint, isn't it? So we need new faces.
So I did, everyone is able to unmute. So Imania, she's unmuted now and she's here. Yeah.
Okay. Right. So case 3 is 4 days old, baby boy. He was well at first, sent home second day, came back on the third day, lethargic with poor sucking and seizure. He was sick looking, hypotensive, cyanose, dehydrated. His heart was normal and his pulses were normal. So what is the most likely diagnosis here?
I launched the poll. Okay, there is a poll here.
No, there is no poll.
There isn't? Okay.
Yeah, because of time, so we'll just go through things quickly. Okay.
Can I talk or yeah?
So what is the likely diagnosis? It is like the previous patients. Okay, it is either sepsis, cardiac disease, or metabolic disorder, right? And then you ask yourself, what metabolic disease? Okay. So this could be urea cycle, maple syrup, or organic acidemia. So you will be waiting for the result. Okay, and here we have the results. All investigations were normal except the blood gas showed pH of 7.1, bicarb of 7, annoying gap of 24, and lactate of 4. And ammonia was elevated, it is 195. Ketones were positive, and acyl carnitine was normal. Organic acid showed keto acids. So what is the most likely diagnosis here? So it is interpretation of the results. These are, bedside, most of them are bedside tests. You have ketoacidosis, right? And you have moderately elevated ammonia. Normal acyl carnitine excluded what disorder?
Organic acidemia.
Yes, so organic acidemia is out. Okay. So what could be the diagnosis now?
Maple
syrup
disease. Very good. Excellent. So it is not urea cycle because there is severe acidosis here. So this is excluded. It is not organic acidemia because acyl carnitine. So the diagnosis here is maple syrup urine disease. So what is the next test you do to confirm this diagnosis?
Amino acids.
Amino acid. And so what is amino acid profile will be?
high leucine and isoleucine, and valine as well.
Very good. So high leucine, valine, and isoleucine. And what about allo-isoleucine? This is basognomic for maple syrup. So if there is allo-isoleucine, this is maple syrup urine disease. Okay. If there is leucine, valine, and isoleucine, likely to be maple syrup urine disease. If leucine is very high, it is more likely to be maple syrup urine disease. Okay. So allo-isoleucine is pathognomic. If it is present, this confirms the diagnosis. If leucine is high, this is also will confirm the diagnosis. So what is your testing strategy here? Do you do whole exome? Do you do panel or single gene sequencing? You have biochemical diagnosis now, right? So you know this is maple syrup urine disease. And you know the gene, صح? You know the gene. Branch gene. Okay, so you start with the management, and it is the same, like you start with symptomatic management. Okay, you admit your patient to the PICU, start your glucose, insulin infusion if there is hyperglycemia, and intralipid. Okay, and you start your thiamine. And if the leucine is very high, then you need to start hemodialysis. So this is another indication for hemodialysis. Maple syrup urine disease with very high leucine. Okay, so this is a gene here, PCKDH. So you do single gene sequencing. And as Hind mentioned earlier on, if there is family history, you know the mutation, the familial variants, then you do target mutation testing, not the whole gene. Okay, excellent. Treatment is the same. So now we are familiar with the emergency management of patients with metabolic diseases, right? Okay, right. Okay. And then you start your special formula. You don't need to know the details here. Okay, right. So we move to the fourth case. Speaker for group 4.
Prof. Actually, I don't have speaker. I was the moderator, but I think Ibtihal, Mutawakkil, and Safa, they were contributing really nicely into this case. So I would like to see if they are happy to come forward.
Okay. So you choose your speaker, okay?
So yeah, I will be the dictatorship. So yeah, I can ask Safa or Ibtihal, please.
Okay. So both, Safa and Ibtihal. Right. Okay, so here we have 1-day-old baby. Was okay on day 1, apparently well. Sent home, came back on day 5. No, this one was actually very sick on day 1. Okay, he was lethargic, with poor feeding, with intractable seizure on day 1. He didn't respond to phenopark, phenytoin, and Keppra. So he had therapeutic trial of pyridoxine, pyridoxal phosphate, and pyodine. And still he didn't respond. He was sick looking, he was hypotonic, and his cardiovascular system was normal, and he had no organomegaly. Okay, so what is the most likely diagnosis here? Patient with intractable seizure on day 1.
In the room, the discussion has been about excluding sepsis, sepsis, meningitis, encephalitis, and then going into the metabolic panel.
Okay, very good. So early meningitis can present, although it is rare and usually they don't present on day 1, but they can present on day 1. Okay, so sepsis with meningoencephalitis is a possibility. And then metabolic disease, right? Doesn't look like cardiac. Okay, so it is either sepsis or metabolic disease. So you ask yourself, what metabolic disease from our discussion? The blood gas was normal and serum ammonia was normal. Okay, intractable seizure on day 1, you suspect metabolic disease. So what type of metabolic?
Non-ketotic hyperglycemia.
Excellent. So that is a diagnosis. So this patient has epileptic encephalopathy. Patient doesn't respond to anti-epileptic medication presenting on day 1 with intractable seizure. So the diagnosis is, the likely diagnosis is non-ketotic hyperglycemia. And there is differential diagnosis of epileptic encephalopathy, that is sulfite oxidase deficiency, molybdenum cofactor deficiency, and pyridoxine-dependent seizure, biotinidase. This is a treatable condition. So whenever you have patient with intractable seizure not responding to anti-epileptic medication, please start biotin, pyridoxal phosphate, and pyridoxine. Okay. Right, so the likely diagnosis here is non-ketotic hyperglycemia. Management is basically the same, you know. Okay, right. And this is the EEG of this patient, which showed hypsarrhythmias. It is highly suggestive of non-ketotic hyperglycemia. So how do you diagnose non-ketotic hyperglycemia? Biochemically, what you do?
Serum amino acid is needed to diagnose.
Okay, so you do serum amino acid in the blood, and in CSF. And you look at the ratio. The ratio of CSF to blood is more than 0.08. This is diagnostic of non-ketotic hyperglycemia. So you check for glycine in the blood and in the CSF. If the ratio is more than 0.08, this is highly suggestive of non-ketotic hyperglycemia. There are few genes that can cause non-ketotic hyperglycemia. So here, usually we go for gene panel, okay, or whole exome rather than single gene sequencing. Very difficult to treat. You start with anti-epileptics, but there is a role for sodium benzoate, folinic acid, and you know, the prognosis is really poor. Okay, and this is again just to remind you, is all differential diagnosis of intractable seizure in the first few days of life. And non-ketotic hyperglycemia, sulfite oxidase, molybdenum cofactor, purine pyrimidine disorder, and cerium disorder. Right. Okay, so by now we finish our 4 cases. So if is there any question?
Actually, in the room, there was a discussion about the exact role of dextromethorphan and folinic acid.
Well, no one knows, to be honest. You know, this medication tried, and they are really not very effective. You know, but it is something you just start. Some of patients, they do respond partially, but there is no dramatic response. And usually these patients, they die in the first few months of life, if not the first year of life. Okay. Right. Okay, so I think we can give you just the grace here, just simple case we finish with. Okay, Usama, sorry, I know you said, okay, just to finish at 9:30. Okay, so this is the 9-month-old boy admitted with recurrent hypoglycemia. Okay, he has hepatomegaly, 8 centimeter. Critical sample showed ketonuria and lactate of 6 and creatinine kinase of 500. So what is the most likely diagnosis here? You have hypoglycemia with hepatomegaly. If I tell you that there is ketones in the urine, okay, so it is going to be ketotic, right? It is
glycogen storage disorder.
So the most likely thing here is glycogen storage disorder. Because the take-home message, if you have hypoglycemia with hepatomegaly, with ketoacidosis once in the urine, with lactate, please think of glycogen storage disease. And most likely this is glycogen storage disease type 1. Okay. All right, so by this we finish. I think if there is any question now we can answer.
So you can stop sharing your screen now, Prof.
Okay. So stop sharing. Okay.
Thank you. Rehab, is there any question at the end to wrap up this?
I think the take-home message here is, you need just to have high index of suspicion of metabolic diseases if any patient in the neonatal, either neonatal period or later on, presenting with unexplained acute illness. You need to do your basic metabolic workup, especially the ammonia, the blood gas. Okay, and then the management is more or less the same. So, you need to start with symptomatic management, admit your patient to the PICU. And if there is hyperammonemia, you need to start your cocktail of ammonia scavengers. I think that is the take-home message from this. If there is any more questions, I'm happy to answer.
No, I don't think. Just hold on.
Okay. So I just want to mention one thing, the thing that's made me think about this, topic, the metabolic emergencies. That's one of the real patients. That was soon, like I was working in the intensive care unit, and around 4 or 5 years old, who presented to the casualty many times, 3 or 4 times, admitted with vomiting, being sick, getting IV fluid, getting better, going home. But then the last admission, he like 3 or 4 vomits, and he was very, very sick, and he had to be intubated, ventilated. And in all of these, he hasn't had any kind of ammonia or metabolic screen or serum amino acids, urine organic acid, urine for OTC or anything. We are about to extubate him and just continue the normal management. But looking back, kind of decided to send an ammonia and a metabolic screen. Because he wasn't, that's like his degree of vomiting wasn't like consistent with how sick he was, and the ammonia came back as 2,000. Was a very big surprise. So the message here that he presented many times, and he could have been, diagnosed, and especially those patients who presented with, who have like an already diagnosis of cyclical vomiting. They come in and they can have like vomiting, they get IV fluid, they get better, but one day, if they are not diagnosed, they can come very sick. So any patient with cyclical vomiting who has like this diagnosis without having a metabolic screen while he is sick in one of the acute kind of admission, you cannot rely on. You have to do this. So anyone has cyclical vomiting coming into the hospital many times, getting fluids, I think will kind of need metabolic screen at one stage. Thank you very much, Professor Sarar. I was like kind of delighted to have you here, and for this very informative session with all of the expertise and your enthusiasm and kind of the presentation, which was very, very nice and well organized, and the cases and the discussion rooms and everything. This workshop, I think, was and lecture is really, really successful. So I hope everyone is kind of benefiting the most of these. And what I'm going to do now is that's in the chat box. I will put the feedback form, but as well at the same time, I'm going to. So this is the feedback form. If you can find it in the chat box, you can all do your feedback. You need your feedback for your certificate. So without the feedback form, we cannot issue the certificate, because this is the way that we use to collect like kind of emails and send you back the certificate. We'll give you 1 week for this feedback, and then we will close it. As well, we will send you an email with individually to all of those who have attended. Now you need to attend at least 1 hour of this session, or between 15 minutes at least, of this session, in order to get like your certificate. And the certificate is going to be approved for CBD as per the RCPCH guidelines. That's mean that you decide yourself how many hours that you have attended, and then you claim your CPD points as per the current RCPCH guidelines. Thank you very much, and I hope to see you all in the next series of pediatric emergencies, and suggest us as send your suggestion as well, as I said in the feedback form. And I would like to thank Rihab Osman for her great efforts in the organization and for the moderation, and for you know, as well working hard to claim the CPD points. I would like to thank all the moderators in the break rooms, Manal, Habab, and Mohamed, and Boran. Thank you very much for being with us, and thank you very much for working hard as well, and for moderating the break rooms, and for working as well behind the scene on admitting people and doing everything. As well, thank you for Dr. Ahmed Shouk, the president of the FRCPCH, the British Sudanese Association of Pediatric and Child Health. And as well, I would like you all to visit our website, psapch.co.uk, visit our Facebook page, subscribe to PSAPCH, become a member, so you can as well benefit from the small group discussion that we do, and the small workshop that we will be doing. Thank you very much again, Professor Sarar, and give you the last word to say the last few words.
Thank you, Dr. Osama. Actually, I'm privileged by contributing to this academic activity. I'm really happy to do that. And as I said, you remind me with my old days, my old friends, and I'm really happy to see Mohamed Adam and so on. I just have one comment. There is burning questions here from Hanan. I think she asked about the presence of ketones in glycogen storage disease. And, you know, we do see ketones in glycogen storage disease. And also uric acid may be elevated, lactate may be elevated, and lipids also may be elevated. So this is just a comment because you asked about this twice on the screen. Okay, so thank you very much. Thank you for the group, and I hope you know, it was helpful. Thank you.
Osama, you are muted. You are mute.
Sorry. Thank you very much, everyone, and see you again in the next series. Thank you, Professor. Thank you, everyone.
Thank you.
Bye-bye.
Thank you.